introduction and yeah, and thank you for inviting me here. It's my first time in Michigan, so it's very nice to meet many old friends and meet new people. Okay, so today I will present my work on related to precision medicine HIV. So we know in many healthcare and medical applications, there are a lot of problems involving sequential decision making. So for example, like in cancer, patients may receive chemotherapy as their frontline therapy, and then if the patient becomes resistant to the frontline therapy, and then they need salvage treatment such as immunotherapy. And another example is for patients after kidney transplantation, and to make sure that kidney works properly, and then they need to visit the clinic from time to time, for example, like every half year or every year. And at each visit, the clinician will need to assign them immunosuppressive drugs. So we need to determine what's the optimal dosage, like sequential optimal dosage of these immunosuppressive drugs to keep their kidney work well. And another example is HIV. And for HIV people, they need to take antiretroviral therapy, ART, every day. So how to determine the optimal assignment of ART for people with HIV will be another example of sequential decision making. Okay, so to determine the optimal sequential decisions, a gold standard we know is conducting clinical trials, right? But however, for the sequential decision making, if you have many stages, and at each stage, if you have a relatively large number of potential treatments, then conducting randomized clinical trials will be infeasible or very costly. And luckily for us, with the development of EHR, EMR data, and also a lot of prospective study cohort data, and we have the potential to determine or optimize sequential treatments. And what is needed is the methods, either statistical method or machine learning method that can give us accurate and reliable decision. So my group has been working on different applications such as cancer, chronic disease, HIV, and COVID-19. So today I will focus on HIV. Okay, so we know HIV stands for human immunodeficiency virus. So it's a virus that attacks human cells that help their body fight infection. So the HIV affects human cells through some pathway. So for example, it first binds the host cell, and then the RNA enters into the host cell, and then it's reverse transcribed to DNA and combines the host cell DNA and then produce small RNAs. And luckily for us, we have so ART, antiretroviral therapy. So the mechanism of ART is the blocks this pathway. So there are several steps of this infection pathway, and they block certain steps of the pathway. So for example, there's one type of ART drug called NRTS, nucleoside reverse transcriptase inhibitors. And this specific drug class blocks the enzyme of this step, this transcription step. And there are many, many different ART drugs. I would say, so for example, now there are more than 30 FDA-approved ART drugs, and they belong to different classes. And different classes have different mechanisms. Like I said, they block different steps along this pathway. So for example, like these are NRTI drugs, and here are the NRTI drugs, we have the names, but yeah, I can skip that, and also PI and I drugs. And interestingly, these two drugs were actually used to treat COVID-19 when the pandemic starts, because we know COVID-19 and HIV both are a virus, and they figured out these two drugs might be useful. Yeah. Okay, so for the ART treatment, and since 1990s, people found out the cocktail approach of treatment is the most effective way. So basically it means we have different classes of ART drugs, and people find out if you take certain drugs from each drug class, and it will be mostly effective. So for example, some typical regimen would be we have two different NRTI drugs and one INSTI drug. Or you may assign two NRTI drugs and one NRTI drug and one drug from the PI class. So that's kind of like cocktail treatment approach. And once patients taken these drugs, and for the standard HIV treatment and monitoring procedure is like the CDC recommends they visit the clinic every half year, so semi-annual visits. And at each visit, there are social demographics information and also lab tests like CD4 count, viral loads, and behavior characteristics. For example, like whether they're smoking and substance use and all those behavior questions, and also clinical factors like their BMI and blood pressure, all those information will be recorded. And after clinicians see this information, they will assign the ART regimen. Okay, so this process repeats every half year. And for now, the CDC already have certain guidelines. Okay, so the guideline for the use of ART in adults with HIV. However, the guideline, they usually only works for treatment naive patients. So what does treatment naive mean? It means people who are newly diagnosed with HIV and they just initiated their ART treatment. However, for people like in our EHR system, they have been, for example, they have been diagnosed with HIV for 20 years, and they have been using different ART drugs in the last decade. And how can we assign them the optimal treatment? So there's no consensus for assigning ART drugs for pre-treated people. And also, the guideline didn't consider possible side effects. So now people, with HIV, they can live as, until the normal people, the average age over 70 years old. So now the HIV is more like chronic disease. And we know you have to take these drugs every day, so they may have some side effects, long-term side effects. So however, the guideline didn't really consider these side effects because, the ART drug, their main purpose is to suppress the viral load. So as long as you can suppress the viral load, it'll be okay. However, they may create some side effects mental health problem, like depression people. So for example, people find out people with HIV has I think 30% higher likelihood of depression compared to normal people. And also other potential side effects, including kidney function, kidney problems, cardiovascular diseases, and also cognitive impairment. So our goal is to determine the personalized ART regimen to optimize people's long-term health. So this long-term health, probably in the next 10 years, 20 years, if we consider all your overall health, your BMI, your kidney function, everything, and what would be the optimal personalized medicine. And not only we want to develop this algorithm, we also want to build a software. So this software is once the clinician input the patient information and you submit, and we can recommend some regimens. For example, here are the top 5 regimens we recommend to prescribe to this particular patient. So the reason we want to build this software is because, for example, now in US, there's not enough ID doctors. So the Academy Executive Director Bruce Pagdewin said, our patient population is growing, but the number of medical professionals specializing in HIV care is not keeping pace. So in many suburb areas, for example, the people with HIV, they are actually treated by their primary physician, but their primary physician may not be trained with ID, specializations. So that's it's only the US. So not mention many developing countries and underdeveloped countries. For example, we have collaborations with Uganda and a lot of different countries in Africa, and they don't even have well-trained physicians. They have more community doctor, so Hopkins, we have the program, we send the clinicians every year to Africa, like Uganda, and train them, the physician, not really physician, but train the people there, and so they can treat the people with HIV there. So if we can do this software, and this software will have the potential to help the people in these underdeveloped countries to treat people with HIV. Yeah, so how can we achieve that? So nowadays we have a lot of data, right? So for example, the data we are using is called MaxWise combined cohort study. So it's a large scale HIV studies. So they record the data for people with HIV and every half year. So they have semi-annual visits. So for example, here is one patient data, and we have here the y-axis. So here x-axis the calendar dates of this person's visits, and the y-axis is their ART drugs they have been used. they have been using. So for example, this person at the beginning only used AZT, this RTI drug, and then it keeps changing. And recently they use this specific ART drug combination. So that's the drug information. And not only the drug information, we also have their health outcomes. So for example, here like the depression data and the viral loads and the EGFR and also the BMI. So we have all this data for every people every half year. Okay, so with this data, and they give us potential to estimate their optimal sequential treatments, right? So for example, when this person comes in, we will say, okay, here is your optimal treatment you need to take that can give you best long-term overall health. But how about the challenges? So we have the data and we know our goal. How can we achieve that? So there are many, many challenges. So here, for example, one challenge is if we want to assign the treatment, we need to first estimate the effects of these different ART regimens from a high-dimensional and unbalanced space. So when I say high-dimensional, it means with more than 30 FDA-approved ART drugs on the market, there are a large number of possible drug combinations. So you can think about it, it's kind of like a combinatorial problem, right? So we have different drug classes, and within each drug class, you have a few different choices of ART drugs, and we need to choose a combination. So for example, in the data set, we have thousands of drug regimens that have been prescribed to patients. And also, the data are highly unbalanced. So like some drug combinations are frequently used, however, some are not. So for example, like this drug combination is 2 NRTI drugs plus 1 PI drug. It was used about like 1,000 times in the data. However, a similar regimen, so the same 2 NRTI drug and a different PI drug, it was only used 12 times in the data. So how can we estimate the ART regimen effect? And another challenge is if we want to assign the treatment to patients, it's kind of like we need to generate a realistic ART regimen from this large discrete space. So a naive way to represent the ART regimen will be say, okay, let's see if I have capital N number of possible ART drugs, I can just use a binary vector to represent my regimen. Say if this regimen has this specific drug is 1, if not, it's 0. But the problem with this representation would be you will have 2 to the n possible combinations, right? But most of the combinations will be unrealistic and will never be prescribed to patients. For example, if everything is 1, that means you use all 30 drugs. That's impossible, right? Usually it's just like, for example, 2 NRTIs and 1 drug from PI or 1 drug from NRTI. So this simple representation will not give you a realistic representation of ART regimen. So we will address this problem later. And another challenge is we want to optimize sequential treatments from observational data. So we have no way to interact patients and say, okay, I randomize patients to different regimens and see what's their outcomes. You cannot do that from observational data. So there's a typical challenge called distribution shift. So how can we address that? So that's another challenge. Okay. So I discussed these challenges, and here is like kind of roadmap of precision medicine in HIV. So first, we need to understand the ART regimen effects. And after we understand that, and then we can optimize ART. And after we can optimize ART, we will find ways, for example, can we incorporate some domain knowledge? For example, can we incorporate because we optimize ART from the EHR data, but there is still some domain knowledge like treatment guideline. Can we incorporate the guideline information into our decision-making framework? That's another challenge. And then that will be our holy grail. If we can build this software and, clinician can actually use that to treat patients, that would be great. So that's our roadmap of precision medicine in HIV. And I will first talk about how to understand the ART effect. Okay. So I will not dig into super details of the model. I will give you big pictures. But to introduce a big picture, I need to introduce some notations. Okay, so let's use Y to denote the depressions. Like for example, if you have multiple health outcomes, like here's depression, if depression is of interest. So let's use YIJQ to denote the depression. So I index patient, J index visit, and the Q index which depression item. And we also have ZIJ to denote the treatment regimen. But here, the treatment regimen is no longer numerical value we usually deal with, it's actually a drug combination. So for example, like here, the ZIJ will be, okay, it's like this drug combination, T4T plus LM plus NFB. And also we have XIJ to denote all the covariance information. Okay, so to understand the treatment regimen effects, so we develop a model. So here is an overview of model. And the first part is kind of like just regular linear regression. So we include this baseline information like demographic and some longitudinal covariance, of course, also like behavior and the clinical covariance into this part. Okay, so this is regular linear regression, very simple. And of course, you can have some mixed effect part there. So that would be regular linear mixed effect model. And the key part of our model is how to estimate the ART combination effect, because the regimen basically is a combination of ART drugs and it's high dimensional and it's unbalanced. So to model this ART combination effect, we want to achieve two properties. The first property is sharing of information between different drug regimens. So for example, if we have two regimens, they have the drug, even they have different drugs, but if they from the different drug class, that means they share similar mechanisms, and we hope their drug effect would be similar. So it's kind of like some sharing information among different regimens. And also we would like to reduce the high dimensionality because we have thousands of possible drug combinations. So how can we reduce the high dimensionality when we estimate the effect? So we develop like kernel type of model. And here is the idea. So we first introduce something called representative ART regimens. So you can think about it like the knots in the splines. Okay, and we define some representative ART regimens, and then we create some kappa function as the ART regimen similarity function. So that can reduce the dimension of estimating all the possible drug combinations to the dimension of only the representative ART regimens dimension. And we only need to estimate this coefficient gamma D, you see the index by D, because we reduce the dimension to D. And the last part is we just have this part to incorporate the correlation among different health outcomes and also independent noise. So again, these two parts, like the green part and the pink part is just a regular model, and a key part is this blue part, how to estimate the ART regimen effects. Okay, now you may be wondering how to define kappa, right? So we find the representative regimens and how can we define the kappa to achieve this sharing of information property. Yeah. So for the similarity function, a natural choice would be linear kernel. So what does linear kernel mean in this context? Linear kernel would say we can compute the similarity between regimens based on the proportion of common drugs that two regimens share. So for example, for these three regimens, so all three of them have two same NRTI drugs, T4T, LAM, and they have a different third drug. So if we use this linear kernel, then the similarity will be 2/3, right? In total of 3 drugs and 2 of them the same, so we can just compute the similarity. However, it has drawbacks. The drawback is that it doesn't take into account the clinical information of these drugs. So for example, like if we have these 2 drug regimens, these 2 drug regimens, they both have 2 NRTI drugs and 1 PI drug, but they have totally different single drug. So if we have linear kernel, their similarity would be 0 because they don't share any drug. However, they share some information, right? So both of them have 2 NRTI drugs and 1 PI drug. So we expect they should have certain similarity. And also, for example, if you just look at these 3 drug combinations, like these two are both 2 NRTI drugs and 1 PI drug, and these 2 are 2 NRTI and here, but here is NRTI. So we would expect these 2 drug combinations should share, they should have closer effect compared to these 2 and this one, right? Because they have the same drug class. So to take into account this clinical information, we utilize subcentric kernel. I think that's the part I like this method the most, is that a substrate kernel actually is not a new method. So it was originally developed in natural language processing literature. They use tree structure to represent the sentences to calculate the similarity of sentences. And here we represent each drug regimen as a tree structure. So the first layer is ART drug, and the second layer of the tree is to denote which drug class this regimen has. For example, here NRTI and RTI. And the third layer is the number of drugs in each drug class. So here represent 2 NRTI drugs and 1 NRTI drug. And the last level is the individual drug in each drug class. So if we represent the drug combination as this tree structure, and the tree kernel actually can calculate the similarity between regimens across all levels of tree representation. So that means the similarity can, like for the regimen A and B, the blue part you see is exactly the same, right? So they both use these 2 NRTI drugs. So the substrate kernel method can actually calculate the similarity between these 2 blue parts. And for the A and the C, they don't share any individual drugs. However, you see this yellow part. So the drug regimen, they all have 2 NRTI drugs, so they should have some similarity. So this tree kernel method, they can calculate the similarity of the yellow part. So here is the similarity matrix we calculated. So we can see A and B has higher similarity compared to A and C, also B and C. And also, if you see the diagonal means self-similarity. So we can see the self-similarity of C is larger than the self-similarity and B. That's also expected because the regimen C has 4 drugs. We know it's harder for the 4 drugs exact the same compared to 3 drugs. So this kind of kernel method can take into account this clinical information, mechanism of the drugs, and also consider the number of individual drugs in each regimen. Okay, so that's a way how we define this kappa function, the similarity function using this kernel. Okay, so that's the overview of the model. And lastly, because we have the Bayesian non-parametric model, I use this dependent Chinese restaurant process, the division process, but I will skip that part. So this part essentially, it gives you kind of like clustering of the patients. So like different groups of patients, they will have different regimen effects. Okay. So that's the model overview. So let me show you one result about this model. So we have one patient, and this patient already had 6 visits. So we have their information like age, BMI, CD4, viral loads, hypertension, substance use, and also their smoking status. And also we have the history of the treatment. So like this one, okay. And then if you apply our model, you can do this individualized prediction. So like here, we consider 2 hypothetical scenarios. If this patient continue to use this drug regimen, and here will be the predicted depression, like different depression items. And if we change to another regimen, so for example, here is 2 NRTI drugs and 1 NRTI drug, and here will be the predictive depression. So we can see if you just look at the mental health of this person, then the clinician would prefer, or the people, we would prefer this drug combination because it leads to lower depression score compared to this regimen. Okay, and we also build a Shiny app, like here, if you just input this person information, and then we will give you the prediction and give you, okay, which drug combination has the best mental health outcome. Okay.
Can I ask you a question?
Yeah.
So in your model, you had Yij on the left-hand side. So that's an outcome at time j, but you wanted long-term outcomes, I thought. So how do you translate something at time j into what you really want?
Yeah, that's a very good question. That will be the second part. So here, this model hasn't touched the part of like assigning treatment. So this model is just like our first try of estimating the treatment effect, because before we optimize that, we want to first understand how can we estimate treatment effect. So this model, if you can think about it, basically is similar to like linear mixed effect model for longitudinal data. The only different like key part difference is like this part, how can we quantify the ART? And I will talk about the second part, like how can we take into account this long-term health outcome. Yeah. So here we haven't touched that part. Yeah.
So is it intentional? You only have main effects here. So, for example, if Xij is representing certain baseline measurements of a CD4 cell count, I mean, that probably is going to interact with Z, right?
Yeah.
Is that doable?
We actually have another part, but I didn't include because you actually can think about another part of the model is still this kernel thing, but then you have the X and times gamma part here. Yeah, because I try to avoid the model to be too complex for the presentations. I ignore that part. But yeah, but we include the interaction effect of the X and the treatment. So I would say it's kind of like the simplified version of our final model, but all the main ideas are here. Yeah. Okay, so now we talk about how to estimate the ART effect. And our second try of solving this precision medicine HIV problem is we optimize ART. So if we want to optimize ART, and we know it's essentially a sequential decision problem, right? So the people at each visit, their health outcomes observed, and they kind of visit the clinic every half year. So for the sequential decision making from observational data, it falls into the research area of offline reinforcement learning, or we call them dynamic regime in biostatistics community. So essentially, you want to estimate the optimal sequential treatments from observational data. And the offline reinforcement learning has achieved a lot of successes in different applications, especially like self-driving cars. And there are many methods and algorithms that have been developed. So there are two types of offline reinforcement learning methods. One is model-based method, and another type is model-free method. So the model-based method basically is like you model the dynamics of their states, and then you optimize the policy. And the model-free method is without modeling the dynamics, and then you optimize the policy. Okay, so to solve this problem, our group first develop a model-based method. So here is kind of like approach overview. So we have all this data, and first we develop a Bayesian dynamics model to learn how their health outcomes evolve over time. For example, like their kidney function and eGFR evolve over time. And after we learn these dynamics, and we put the dynamics into an offline reinforcement learning framework and create some pessimistic environment for their distribution shift issue, and then we optimize the treatment. So it's kind of like a two-step approach. We first have dynamics model, and then we optimize policy. So let me give you a little bit detail about this approach. Okay, so the problem formulation is like that. So we assume we have baseline covariates like age is not. So like race, ethnicity, these are baseline covariates that do not change over time. We have X at 0. And also we denote TI as a visit times, like TI1 to TIJI. So each person has JI visits. And also we assume we have M-time varying health state variables, like here BMI, kidney function, very low CD4 count. And also we have, again, similarly, we have ZI as a treatment. Okay. And we use D to denote all the data. So we have capital I patients. And also because we know for this dynamic sequential decision-making problem, the state and the action depends on all the history. So we have this history variable, like we use the YIJ bar to denote all the health outcome before visit J, and the ZIJ bar denote all the treatment history before visit J. And also we assume the health outcome, they evolve over time following this dynamic model with some parameter data. Fine. Okay, so our goal is to optimize ART assignments to maximize individuals' long-term health outcomes. And essentially, because we want to optimize the ART assignments, it's an optimization problem. So basically, let's say if for any individual I, suppose that she already has GI visits, and we use YI new and ZI new to denote the future longitudinal states and ART regimens. And also we assume we can assign treatment following some policy function like pi here, ZIJ plus 1. So that's the treatment assignment of next step, given the whole state history and whole treatment history. And we have assumed this policy function is parameterized by some parameter theta. And also we assume the reward function here is a function of the states variable. So for example, let's say we want to optimize the overall health. So we may define your reward as some like weighted sum of your different health outcomes, like some weighted sum of BMI, EGFR, and also like mental health variables. And the goal, and also we denote the expected reward for any individual I to be like here. So we can see the expectation of the reward, but with respect to the dynamic model here, the distribution of your YNU and the ZNU. And also you'll notice here, we have P5 condition on D. So that's, here is a joint distribution and here is uncertainty from a dynamics model. So I think that's also kind of like one advantage of introducing Bayesian model here is we can take into account the uncertainty in the dynamics model in the decision making, and we integrate out phi. Okay, so basically we denote the expected reward and we want to find the theta, so that's in the policy function that optimize our expected reward. So it's kind of like we formalize our, assigning sequential ART regimens problem to our optimization problem. So as long as we get this optimal theta star, and then you have this optimal stochastic policy. Okay. So how can we do this optimization problem? And there's a standard method, not standard, a classical method in the offline reinforcement learning is called policy gradient method. It's like as long as you can calculate the gradient of your reward function, and then you can do the optimization through the stochastic gradient descent, right? So for example, if you can calculate the derivative with regard to theta of your expected reward function, and then you can update the theta. So here the problem is how do we calculate the derivative of this reward function? And here is a reward, the definition of the reward function is expected reward after you integrate out the uncertainty in the dynamics model. And luckily for us, we can actually calculate that. Okay, so here is a formulation. I know it's kind of like some small notations you probably cannot see from the back. But let me decompose that into different parts. So actually it has three major parts. The first part is a log policy function. So that means if you can parameterize the policy function, you can write down this part by analytical form. And another part is the expectations with respect to the joint distribution. So that means if you can have a joint distribution on the state and the treatments, and you can sample future states, and you can do this expectation numerically. And also the last part is the reward function. So how can you define a reward function? So the formula here is complex, but actually it's only these three parts. So as long as we can parameter the policy function, define a reward function, and sample future states, then we can calculate the derivative and plug into the stochastic gradient descent, then you can optimize data. Okay, so now let's talk about the first part is how to sample the future states. So now we have multiple longitudinal states, and we may have missing data here. And we just adopt a multivariate Gaussian process to model the longitudinal measurements of all these health outcomes. And I didn't include the detail in this presentation, but you can remember the first project, how we estimate treatment effect. And in this multivariate Gaussian process, in the mean parts, we also have that kind of like the substrate kernel approach to include the treatments into the longitudinal data modeling. Okay, but I will skip the detail here. It's big picture, it's just a multivariate Gaussian process. And for the second part, the reward function, and we define the reward function here based on very low kidney function and depression in the next 2 years. Of course, we can include more health outcomes. And here is our reward. So basically, people have semi-annual visits. So we have sum of from next 1 visit to 4, like +1 to 4. Here, this is next 2 years. So the reason we choose 2 years is because the new treatments are still evolving. So you don't want to plan so far away from now because the new treatment may come out. So we have this 2 years threshold. And this term is depression. It's like, so we know the depression is smaller the better. So we just have this W times depression part. And for the very low and the EGFR, because they have a normal range. So we kind of like, we design this reward function as if they are in the normal range, then it's good. So it's 0, because here it uses a negative sign here. So just 0. And if they are without of normal range, and then we penalize them. Okay, so you can see some weight times some difference between the your value and also the threshold, the normal threshold. Okay, and also we have this personalized weight. So like we actually do the optimization if you can actually define the weight here by the clinician or by the patient themselves. For example, if this person, let's say, if we have BMI and depression, and this person cared about weight gain more than depression, then you can have higher weights for BMI. Yeah. And also, we not just this reward, we actually define some uncertainty, penalize the reward, because to address this distribution shift issue. So our idea is simple. So it's borrowed from it's a method called MOPO, and their idea is they create a pessimistic environment by defining this pessimistic reward. So idea is you penalize the reward by some uncertainty of the state action pair. So from the statistic point of view, you can think about if you only observed some treatment a few times, you would have higher uncertainty here, right? So basically, this pessimistic reward, you penalize the treatments that rarely assigned in the data. And we can calculate the uncertainty actually, because we have a Bayesian model, so that's good for us. So we can just easily calculate the posterior predicted distribution and then calculate the uncertainty and then do the penalized reward. Okay. So now we talked about we use the multivariate Gaussian process for sample future states, and we define reward function. And the last part is how to parameterize the policy function. So again, here we utilize the tree representation of this ART regimen. So that's again, it's my favorite part. So here we create some decision process for assigning ART. So for clinician, there is that when the new patient comes in, they will say, okay, if everything is normal, if everything is normal and okay, they will just keep the current regimen because the current regimen is working. So basically, the first step is decide whether you need to switch. Okay, so we have some probability to model that. So if everything is in the normal range, then you keep the current regimen. So here stay. And if you need to switch, then how to generate the new regimen. So we generate a new regimen based on, again, the tree representation. So basically, you first decide, okay, which drug class I want to use. And then after decide which drug class, and they decide, okay, what individual drugs I want to assign. So for example, like in RTI, you have like 12, 13 possible choices, and you choose from them. So basically, we use a multi-class logistic regression model to parameterize that selection process. Okay, and lastly is when you choose an individual drug, then it's non-central hypergeometric distribution. And then you get the product of these three parts. Yeah, I don't have a formula here, but you get the product of these three parts, it will be our decision process. So that's our parametric policy function. And you have parameters here, and then you can optimize. So like here, so we have the multivariate Gaussian process here. We have pessimistic reward here, and then we have the parameterized policy function here, and then we can optimize data. Okay, so that's kind of like the overall picture of the method.
Can I ask, so I'm confused about theta here. So it's a policy, it's a deterministic policy, or is this sort of stochastic probability you'll take one treatment or another treatment or some combination?
So in this one, the policy will be stochastic because it's a function pi conditioned on the treatment and the state history parameterized by theta. So for example, if you have the theta, and then you will know the probability of assigning each possible drug regimen. So this one is a stochastic policy. Yeah.
So you're optimizing a stochastic.
Right, this one we're optimizing. not a fixed policy. But next part, I will talk about the fixed policy because we talk to clinician, they don't like the stochastic policy. So they don't want this. Yeah, but anyway, so yeah, for this one, I like to give you a quick example of the, how they achieve precision medicine. So let's say, assume we have one patient here is a treatment history. So this person already has 31 visits. It's about like 15 years of data. And this person, everything is relatively normal. So we just give them 1/3, 1/3, 1/3 weight. So like no preference on any part of health outcome. And then here is our prediction. Okay, so we predict next four visits, next 2 years, and here is the optimal treatment regimen. Yeah, so our model can achieve that. So for each person, you can give them this. Again, it's stochastic, but you can think about it's kind of like the posterior mode. Yeah, and also we predict if this person use this specific regimen along the time, and then we can see the depression will reduce to this range. So that will be a 23% improvement of their mental health outcome. Okay.
Sorry, so on my previous slide, doesn't it? Time, visit 33, doesn't it depend what happened at the outcome at visit 32? The next slide, I guess.
Right, so here you can think about we integrate out because we have a dynamics model of all the Y and the Z. So we optimize Z. You can think about we actually marginalize out the Ys. So basically, like a multivariate Gaussian process give you the predictions of next 4 visits, but when we optimize the treatment, we marginalize them out. Like it's kind of like you account for all the possibilities of Ys, and here kind of like overall best treatment regimen.
So this particular patient did have something happened at the end of visit 32, he got bad depression. He might change the policy on the next decision, next visit?
So here is kind of like we predict let's say the depression in the next 4 visits, and then you have some posterior predicted probabilities of the depression. And then, for example, for each potential depression, you will have a different assignment, right? So it's kind of like we average over all the possible values of the depression. And here kind of like overall optimal treatment regimen. Like the mean, like expected mean. Yeah, it's like we marginalize out all the possible Y. But you can only do this because we have a Bayesian dynamic model in the first step. We know the dynamics of Y, conditionalizing, of course. Yeah. So however, when we try to we built a simple R package and we found it super slow. Like when we talk to clinicians, say, okay, we have this algorithm, let's use this to treat patients. But we found out it takes like 5 minutes to optimize one patient data, and they don't want to wait. So we want something fast, like actually. So to be honest, like when I try some R package, if it takes more than 1 minute, I will be. So I don't want to use it. So I kind of totally understand. So and we'll say, okay, is there any way we can improve our model and make it faster? So we recently developed a new method we call HIV AI care. So it's we're wrapping up now, so it's to be submitted. So here is kind of like the overall flow of the method. Okay, so rather than the slow part of that model is because we took this model-based method. So we have the multivariate Gaussian process to estimate dynamics, and then we have this policy optimization step to optimize the parameters. So that's why it makes very slow. So we say, okay, maybe we can use a model-free method. So because in general for the reinforcement learning algorithms, model-free is faster, much faster compared to model-based method. So we developed this method based on the model-free method. So again, here we have a bunch of data sets. So we have the treatment history, and then we have demographics, longitudinal outcome, and behavior characteristics. So here the complexity are manifold. For example, like how to represent the drug regimen. So we have already solved that problem using the substrate kernel, so it's good. So here basically we calculate the substrate kernel. We calculate the similarity among all the regimens based on the kernel methods, and then we do some PCA. You can think about it like embedding of the treatment space to some numerical value. And also another challenge about this model-free reinforcement learning method is, so most of the reinforcement learning methods, they build upon the Markov decision process assumption. So basically means there is Markov assumption. So everything only depends on the previous step. So however, for our application, it depends on the whole history. Because for example, if this person has been using a specific drug for 10 years, they may have higher toxicity. So we need ways to account for the whole history in this reinforcement learning framework. So we invent some like LSTM, so long short term methods of the LSTM to represent the whole history. So basically you can think about, we have all these state variables and all the action variables, you put them into LSTM, and then they give you a representation of all the history. And then we have all these embeddings to kind of like Q type of, so it's a little bit more complex, but it's built on like Q learning, like tricky Q learning. And then we put them all into the Q learning framework, and then you get the estimated Q value. So Q is basically, it's a function of, all their history and A. So in general, the Q function is state action value, right? It's like SA, but we change this, replace this as to H. So like all the history. And basically the model can achieve that if, when you have a new patient, you give the whole history of that patient, and we can easily represent this person's history, and then you can get the optimal A. So in this part, that will be deterministic policy. It's not a stochastic anymore. And here basically, sorry. Here is a model structure. So like we have this tree representation, and then here, we have the current state action and all the historical, and here is LSTM layer, and here is some current representation, and you put everything together, and then you get the estimate Q. Okay. So here the structure of the method. So let me quickly show you the results. So here we randomly selected 2 patients to see their data. So here we output top 5 regimens. So here, we don't want to just put top 1 because the clinician also wants some flexibility. So we give them top 5 choices. So here we give them top 5 choices, and the red one is the clinician, the treatment the clinician actually assigned. So we see the clinician is not doing that. It's actually the number 2 treatment. And we want to investigate why our algorithm recommends the first one, not the clinician's policy. And then we dig into this patient data, and we found out this person is relatively depressed. So here we can see that depression score over time. And then we plug in the depression score and plot the Q value here versus the depression score. And he very interesting finding. We find out when this person, so by the way, here the blue line is the clinician's treatment, and here orange one is what we recommended. So we can see here when this person is relatively not depressed, when the depression score is small, actually the patient recommendation is the best. Their Q value actually is higher. However, when the depression score is large, and our policy wins. So I think here you can see that discrepancy is because that when clinician, when they follow the guideline to treat patients, they kind of only consider the viral load. They didn't consider the mental health. So if you consider, and they basically assume, okay, everyone, your mental health is okay, so it's good. So they just follow their experience and just assign this second one. However, if you take into account the mental health problem, actually the first one give you a better score. So that's one example. And the second example here is another patient. Again, here's top 5, and the clinician is the third one. And then we dig into this person data, and then we found out the clinician assigned this one is because this person has been using this treatment regimen for a long time. So the clinician just assigned this treatment regimen. However, if you look at here, the EGFR, that's kidney function, and we found out when the kidney function here, EGFR is small, actually our method is better. Okay, so again, it's kind of like, if you only consider the viral load, the clinician recommendation might do well. However, if you consider other side effects and other health outcomes, you may have different optimal treatment regimen. Okay, so that's the result of HIV AI here. And then we kind of like, we solved these two problems of estimating the ART effect and optimize ART, like from different angles. And the next part is how to incorporate the domain knowledge. So that's work we're currently doing now. So to be very brief, so how can we incorporate the domain knowledge, or what is domain knowledge? So here we define the domain knowledge as like treatment guideline and also past the literature. So for example, if there are some old clinical trials data and they found out, for example, if you have kidney failure, then you better not use some treatment regimen. So we have all the treatment guideline and a lot of these clinical literatures. And we want to see, okay, how can we deal with this text information? So that's a part of large language model plays effect. So for example, if you ask ChatGPT for, so here is a whole example, like my prompt is, suppose you are an AI physician and you have an HIV patient whose viral load is 10,000, BMI is 22 and has diabetes. What's the top 5 ART regimen would you recommend? And here is what, I know you couldn't see there clearly, but here is what ChatGPT-4 recommends. And actually what they recommend is okay. We found out they actually kind of like give you the guideline information. So it's very closely, it's not the exact same, but it's kind of very similar to what the guideline recommended. So I think we also played around with, ChatGPT-4 and Llama 2 and also different large language models. ChatGPT-4 performs the best in this way, just like, for example, reading the text information like treatment guideline. However, they still didn't consider a lot of side effects. For example, like diabetes here. So the ChatGPT-4 doesn't know how to deal with diabetes information. So we think, this large language model, it performs okay, but it's not good enough. Okay, so what we're doing now is we're combining the large language model and our reinforcement learning framework. So essentially you can think about, like we do the fine tuning of large language model. We have all this guideline information and the literature. Like now we already have like the publication database, like hundreds of HIV literature, and we're doing the fine tuning of LLM. And then after we have the fine tuning, and then we will combine them with our reinforcement learning framework, so they can kind of like better adjust our reinforcement learning recommendations more aligned with treatment guideline. However, you still consider the side effects from the EHR data. That's what we're doing now. And also one step further, we're actually kind of considering a more advanced framework is large language model plus reinforcement learning plus human feedback. So here the human feedback actually means the clinicians' expert knowledge. So what we're doing now is that we have our algorithm. So let's say, either we have a combination of the LLM or not, and we have this top, for example, like top 5 or top 10 recommendations. And now we have 3 clinicians in our group. So we give them, like, for example, 100 hypothetical patient scenario and say, okay, here's recommendations given by our algorithm. Can you give them score or can you rank them? So we're still kind of now working on like what kind of data and what kind of results we give them and how they evaluate. But let's say now we have already determined how to evaluate that. And let's say they rank the data. And this information, you can think about it will be the new information to our model. So you can think about it's like kind of inverse reinforcement learning. So that your method outputs some results and you have some expert knowledge and they kind of refine your recommendation. And you can put those information to the inverse reinforcement learning to your model, and then you retrain your original model, get some new model. Here we call it a aligned model. So it's kind of like the learned reinforcement learning policy after applying this reinforcement learning human feedback. Okay, so that's kind of like our final step. After we do that, and then we're also kind of building the prototype of the software. And after we finish this, then I think it will give us more promising results compared to the algorithm now gives us. Okay, so that's all there I want to talk about today. So the last slide is about some future work. So now we consider some small number of factors, but we want to incorporate more factors. For example, like cognitive impairments and also some other factors we haven't considered, but we will incorporate them all into our function. Or like when we build a software, we want it to be flexible. So for example, if the clinician or the patient themselves, if they want to care about these points, and you can include them into your reward function. So we can give that flexibility to the model. And also we want to do the polypharmacy for aging people, because for those HIV people, when they get older, they also have a lot of comorbidities like hypertension, cardiovascular, and also they are taking a lot of other non-ART drugs. So how can we estimate the drug interactions between ART drugs and non-ART drugs like polypharmacy? And how can we incorporate that into the drug recommendation? So that's also one future work. Another one is unmarried confounder. So we know now we assume everything we have observed, but in the causal literature, there are also like challenge about some unmarried confounder. So my group now is developing some theory, but we're still kind of figuring out how to kind of combine the theoretical parts into these actually practical algorithms. Yeah, and again, there are some also other methods, for example, how to quantify the state action pair uncertainty. So, if we have this model-based Bayesian model, we have ways to easily quantify. However, if we want to make the algorithm faster, we have these model-free methods. There's no way to actually quantify the uncertainty. So we're trying to see if there's any efficient way we can quantify the uncertainty, and also see is there theoretical guarantee for this uncertainty penalized policy optimization method. And also, like Jeremy just asked, the stochastic decision. So we are still kind of balancing, like stochastic versus deterministic, because in some scenarios, clinicians may prefer stochastic, but sometimes they prefer deterministic. So now we are putting like top 5. It's kind of like the middle ground, but we're still thinking about if there are any better way to deal with that. Okay, so lastly, I want to acknowledge all my collaborators, my students, postdocs, and collaborators from Hopkins and Yanxu from Python A&M and Georgetown and Washington, and also all the participants. They contribute data to MaxWise cohort study and also funding. Okay, thank you.
We can take a few questions.
Good.
I have a question regarding, so there was one thing that you mentioned, like how do you decide, so you first decide the drug class, and then you decide in the selected drug class, which drugs to use to build the regimen. Could you tell us more details about what's the decision process?
Oh, yeah, so here basically it's like how we parameterize the policy function. Okay, like here. So you can think about we have 6 drug classes. So you can think about if you want to parameterize this decision process, it's kind of like the logistic regression, right? So from the 6 classes, which classes I want to draw the drug from. And here, so that's why I said here we use a multiple class logistic regression model. So you can think about you have pi, probability of choosing some drug class, and equals to you parameterize some condition on some covariates.
So you can choose from multiple drug class?
Yes, you can. So regimen example I give you can have 2 NRTI drugs plus 1 PI drug. That's regimen. Or 2 NRTI drugs, 1 PI, 1 NRTI. So there are many different combinations. But usually the NRTI, so there are some medical background here. So usually the NRTI is backbone treatment, so it's kind of always included. But then you can choose some other drug classes. Yeah, and the last level is after you determine, for example, which drug class you want to draw the drug in and draw the drug from. And then, for example, if you have 10 possible drugs there, then it's just the non-central Hamilton multi-distribution that you can draw the individual drugs from this specific drug class based on the drug class you have already determined. Yeah. Oh, sure.
So I had a question on the first part of your talk, the non-AI part. So you had these depression scores, right? So are they the survey score that they get usually from PHQ and so on and so forth?
Yes. Yeah, they are. So here the depression score from CSD. It's similar to PHQ-9.
Yeah. So as far as I understand, it's a huge jump when you go maybe below 20 or below 30 to close. That's like acute depression.
Right.
No. So how do you because those means clinically something, like you can easily bucket them like 0 to 5 or 4 to 14, I think there are some clinical decision making that happens. So treating them as, you can treat them as continuous, but in terms of like a jump between classes is of much more clinical importance than.
Right, yeah, so, yeah, it's a very good question. Yeah, for CSD, yeah, 16 is a threshold. So people think like, if your score is over 16, the overall score actually has 20 questions and each question is from 0 to 3. So total score is from 0 to 60. And if it's above 16, then they say this person has a high risk of, so it's not clinically diagnosed, but a high risk of depression. So here, so it's a valid concern. So we kind of get rid of that problem by, so here we have YIJ is not a total score, actually it's like Q-dimensional. So we categorize them into like 4 different symptoms, like somatic symptoms and positive symptom and negative. And also, so we have like for each symptom, and then the range will be small. So we'll try to say like here, yes, here is like somatic, negative, positive, and interpersonal. So here is kind of like the jump is relatively small. And see for example, here you can see the data. It's kind of like we analyze you can think about it's kind of like more like item level, not the total score level.
So is that a manifestation of your the Chinese restaurant process that you're getting this?
Oh,
That's an
this
output.
one actually is known. So people already know how to categorize these 20 items into different symptoms. So the Chinese restaurant process is for classifying patients. So it's not here. Yeah, so here is just known information. So we have these 4 symptom items. Yeah, so sorry, it's like 4 symptoms. And each one will have several items of these 20 questionnaire questions. Yeah.
Sorry.
So how your recommendation depends on your model, dynamic model in the model-based approach, like, for example, go back to this first modeling. You didn't model any interaction between treatment across different time points, right?
Right.
So I just wonder, have you tested, like, if you include a term in the modeling, how can that affect your recommendation eventually?
Yeah, it will, because so here, you see, we're maximizing the role function, and the role function is taking respect to the distribution.
Yeah.
So that basically means if you're kind of like, for example, if you learn different dynamic model, then here will be different, and then your automatic optimal.
Did you look into this kind of sensitivity type thing?
We haven't, we didn't do that part. So here, yeah, I think that's a very good point. So here we kind of we use the Marquardt-Gaussian process. We suppose it's ultimately it's not good, like perfect. But that's kind of like the best, option we choose. Yeah.
We did similar project kind of thing, and the other thing with our data is because it's observation study.
Mhm.
So we know treatment is informative. So in other words, I think it's more reasonable to model jointly about the Y and the treatment assignment of 10 points if you try to make a model more sophisticated.
Oh, we actually have the mathematical. So here we model the Y conditional, say.
Yeah, but I'm saying Z also need to model because Z can depend on latent variable, which might
Right.
be associated with your outcome Y.
Yeah, so that's kind of like this part, like we.
No, that's a policy, that's your policy. I'm talking about
Yeah.
even we build this dynamic model,
Mhm.
you also model this treatment process over time as well. Because it's observational data. So.
Yeah, I think that's also, that's a good point. So we thought about that. So for example, you can model, let's say, like you can model Y conditional Z and then Z conditional Y, right? So you can propose this joint distribution. And then you can estimate. So I think we have another project on kidney transplantation data. We actually did that. So we jointly model Y conditional Z, Z conditional Y this sequentially, and we estimate the parameters. And we found out because in the optimization step here, because what you care about is kind of like the dynamics, why it doesn't involve the probability of Z. But at that project, I think it's good with like we use the estimated policy parameter as the initial value of our policy optimization step. We call that is kind of like imitation learning, right? So you're learning how physicians treat patients in the data. We use that initial value, it makes the optimization steps more efficient. But from the optimization part is like learning that part is actually not useful or it could not be used in this step. But I think you mentioned a very good point is like if we can find some way and incorporate the, what you learned from the data to the optimization, I think that would be great. Yeah. That's a very good point. Thank you.
So I have a question about AI part. So can you go to the reinforcement learning with human feedback?
Oh.
Yeah, so. Right, so you have this graph, which you have to go through the purple, which is to learn the reward.
Purple?
Sorry, pink.
Okay.
Pink node. So recently, I think there is a paper called the Direct Preference Optimization (DPO), which says that after you have generated using LLM, you provide 2 generated results and you rank them. And you do this multiple times, say, I don't know, 1,000 times. So by learning from those pairwise ranking models, you can bypass the need to learn the reward model. So it's based on the Bradley-Terry kind of model.
Yeah.
So I think the criticism of this kind of approach usually is that you have to, the reward model could be very noisy after you learn this. So I don't know, I think that could be one way to probably, an alternative way to tune the large language model. Just want to provide that alternative approach to see how things would go.
Okay, yeah. Yeah, I think that's a very good suggestion. Probably, I think the only bottleneck would be the computational sources. For example, like I think now, like when we do the fine tuning of M, it already takes like 1 or 2 days to do the fine tuning.
Yeah, so that DPO is faster.
The faster, okay, I will look into that. Thank you. Yeah, here is like, yeah, I think here is more like we're trying to kind of like optimize our reward function. So that's, that's the inverse reinforcement learning does, like, after we have this working data, we kind of go back to the reinforcement learning algorithm and tune the parameters there. But yeah, I think you mentioned a very good point. If we have ways to, like, if that's faster, and I think, yeah, we can easily do that 1,000 times. Yeah. But then the way is like, we need to do this expert knowledge part 1,000 times. I don't think the clinician, they want to rank this 1,000 times, right? So I think if there's a way, for example, we only need to do this once, but you still have like 1,000, I don't know, trials of outputting the optimal policy. Yeah, I will think about that. Thank you for the suggestion. Yeah.
So how would you validate your optimal policy?
Oh, sorry.
How would you validate your optimal policy?
So now, no, there's no gold standard here validates the policy. So I think that's why we did this kind of, like case study. And so first say like, if our.
This pure function estimate from your training data, from your data.
Oh, if we talk about the numerical stuff, yeah, we actually kind of like separate data to like training data, testing data, validated data, testing data.
No, but testing data is not follow your optimal policy.
No.
Right.
Yeah.
So basically you cannot validate that. Can you?
Scientifically, you cannot, but numerically you can do the policy evaluation, right?
But you need to simulate the data based on your model, right? You have assumed the model estimate from training data.
Not really. So there are some methods that do the offline policy evaluation. So like you only have the data and then you can evaluate different policies on the data without generating new simulation data. So I think you can still do the offline policy evaluation. But
the subject not follow your policy.
right. Yeah. But to be honest, if you ask me, like, can you really trust that? Because there are different methods to this policy evaluation. Yeah, I don't know which one is like, but of course, like numerically, you can definitely do the policy evaluation. For example, like here, we actually do the policy evaluation, like we compare our AI policy and the clinician policy, and we found like over 90% times we always give higher reward. But again, after automated is more like numerical stuff. It's not like really, scientific validation of. So that's why, here we want to see if our recommendation is actually reasonable.
It's
But-
possible you start a clinical trial and recruit patient and follow your policy and see what's going on.
If we can do that, yeah, I think what.
You have done that before or?
I haven't done that before, but I think it's possible because I talked to a clinician, I know it's like, so now I know people how to test algorithms, right? So for example, for these ones, you don't actually kind of trick people. It's more like recommendation. It's like when the patient comes in and then you ask the clinician assign that, and then your AI algorithm give their give their recommendation, and then the clinician will kind of like safeguard the recommendation that you can do these clinical trials. Yeah, but I think for this example, there's another hurdle, is that, you know, the outcome here is not like, for example, if you do the ICU patients like sepsis, right? It's, you know, what people really do is reinforcement learning algorithms. You know, the clinician's goal and your algorithm goal is the same, it's prolong patient's survival. However, here, we find out the clinicians, because like, especially for people without HIV expertise, they really just follow the guideline and say, okay, this drug combination can suppress the viral load, I will use this one. So there is no comprehensive guideline or any document that tells you, okay, if you want to suppress the viral load as well as keeping this person, you know, BMI in the normal range and the kidney function in the normal range, everything, like what's the optimal treatment. I mean, even the clinician, they don't know that. So I think here it's kind of also, it's kind of like the, you know, the clinician's goal and the AI goal is not exactly the same. So I think that's another hurdle here, but I think that's also kind of motivation why we are developing this, because, you know, there's some parts of this problem clinician couldn't think of, so we can incorporate that in their decision-making process. Yeah,
Thank you.
thank you.
Good questions? Okay, let's thank our speaker one more time.